good afternoon. Welcome to now part 8 of our Accreditation 360 video series with no end in sight. Kind of hard to believe. So I guess Mark's, 16? Actually, I guess it's technically like 17 and a half weeks since they announced it, because it took, we did the first one 10 days after the announcement. But we welcome you all. I want to welcome our subject matter experts today, who should be pretty familiar faces by now. Dr. Edwin Lofton, who leads our Accreditation Readiness Network. And if you're one of those members, make sure you jump over there and get your CECs once this video gets posted. And Howard Nussman, who's been around with us for more years than we care to count.
Thanks.
Yeah, well, I'm including myself in that one. So, so one of the things we're going to do during our pre-discussion, we were talking about the fact that the Joint Commission, I'm sorry, I got to stop using the University of Ohio or whatever, the Ohio State. And there's no longer the Joint Commission. It's just Joint Commission. Joint Commission is continually updating these standards and the survey process guide and some of the other things. So we're going to include that link down below so that you can go and find those updated standards. Of course, as they, we're staying on top of that, and we'll keep talking through those changes as we see those. But today we're going to talk specifically about medication management and the national performance goals, and how that module is different than the chapter was in the previous, or I guess really the current standards that are currently enforced. I feel like I need a little medication management today, but I think y'all are going to talk about a whole different side of that. So let's start, Howard, with you, and just going to talk about medication management in general and how it's changed going forward, and the new module, how it compares to what the old or the current is.
Sure. And I'd like to start off just pointing out something. We had the opportunity to be with the Joint Commission a few weeks ago, right? Yep. And they talked about Accreditation 360. They also talked about, they provided a current or their most recent data about what is scored most frequently in accreditation standards. And they were in accreditation surveys. And they were very insistent that if you are prepared in 2025, based on the 2025 manual and the survey process, if you're ready for survey under that set of resources, that you would do fine and you would be ready in 2026. We're all a little suspicious of that because there's so much more information provided in the survey process guide in these CMS modules than has ever been documented before in elements of performance or things that the surveyors have paid attention to. So I think they're going to be digging a little deeper, being reminded of some of the things that CMS expects. But anyway, in the data that they were showing us, we looked at the top 10 or so clinical standards. There was one of those that was a medication management standard it was number 2 on the list of most frequently scored clinical standards, and that was Medication Management 060101 EP3, which now is totally irrelevant because it has a new number. But it was the one that had to do with following the physician's order. And they specifically described in the handouts that they provided that had to do with titration and not adhering to the medication order or the protocol for titration, which we've seen a lot in our own mock surveys, or giving a higher or a lower dose than what the physician or other practitioner had ordered, or not documenting when there was a deviation, because maybe the patient said, well, I know my pain's at a certain level, and the order is saying this particular medication, but I just would like Tylenol. So there not being documentation to justify not following the order, but doing instead providing the medication that the patient preferred for that pain. So that was like the number 2 on the list. And I would say, if you're being surveyed, it's something you got to have. It's got to be a highly reliable process. and what may be working today may not be working tomorrow. And so you need to know that they're going to look at that, as well as anything that was on your own prior survey report. And those would be the first two things if I were, let's say, the chapter leader for medication management, or the director of pharmacy, the director of nursing, that I would be looking at in terms of requirements for medication management prior to survey. Um, and then if you look through the survey guide, as well as the standards for medication management, there are several big buckets of requirements that stand out. They were there in prior years, and I think they will still be important. One is antibiotic stewardship. They give a lot of ink in the standards in medication management, as well as if you look in the survey process guide, there's a whole new antibiotic stewardship tool, evaluation tool, in the survey process guide that you want to take a look at. And my experience in our mock surveys is that hospitals really are doing a good job with antimicrobial stewardship, or the Joint Commission documents refer to antibiotic stewardship. But you got to show that when you've made improvements, you sustain them.
Mhm.
And it's part of the required documents. So you just want to, if you've really done an excellent job, as many organizations have, put all that data in the PI data that's a required document for the first day, and just show it off right up front, set a great tone for the survey. And then there will be most likely a session to talk specifically about antibiotic stewardship. And so you want to have infection prevention and medical staff and pharmacy and lab all together to talk about how, as a team, you keep track of, how are we doing with our uh, approach to being good stewards.
And Howard,
The other big, yeah, go ahead.
Howard, to reinforce what your comments are, the importance of antibiotic stewardship, that is one of the standards that they've moved from medication management to the national performance goals. So what used to be MM 09, 01, 01, EP 13 about antibiotic stewardship, it is now an NPG 140601 EPs 1 and 2. And for you all that have bared with me over the past 16 weeks, I'm going to be a broken record again. This is where, through NPG, they focus on performance improvement, to what Howard was just speaking to. And this is where the leadership is accountable for the ownership of knowing what performance improvement found, how they adjusted it, and how they provided the resources. So again, antibiotic stewardship, pressed hard on leadership.
It's good. I know
Um,
we're getting ready to do some videos about specifically aimed at leadership and their roles and responsibilities. But I mean, we keep talking about all of this information that needs to go to leadership, including the board. And it's like understanding how limited their time is and how much information they're already getting. It's just, it feels like all of a sudden we're going to be just like cramming, Wikipedia in front of them every single board meeting. It's going to be interesting to see how folks manage that. And of course, we'll be working to try to follow leading practices and share those with everybody, because there's going to be a transition there. I think I'd love to be a fly on the wall in some board meetings as we start to roll this out. But
yeah. Um, and and antibiotic stewardship is an example of, there's a set of requirements, and some of them are CMS conditions of participation. And those, so at medication management 180101, there are some requirements about antibiotic stewardship. And then there are some things that go beyond the conditions of participation that are in what Edwin was mentioned as far as the national performance goals. So they've made it a little more challenging by taking those standards and requirements and splitting them into two different chapters, and we're starting to work with some organizations about, so what does that do to the structure, the infrastructure in place to support continuous survey readiness, if chapter leader doesn't make as much sense as it did in the past, because you have a one topic like antibiotic stewardship, and it's split up into multiple chapters and multiple modules in the survey process guide. So there's a second big bucket around compounding sterile products, and that there's a medication management standard with a number of requirements under it in the new manual that give you, in general terms, the various areas of sterile compounding and how to address that. The detail, of course, is found in the USP regulations. And so whether it's hazardous medications in the USP 800 or in 797 or 795, you're going to go there to get the detail as to what you need to be in compliance with if you are compounding those products. But it's probably going to be involving two different surveyors during the survey process, as it has been in the past. So you'll have someone, and required documents are all the reports from the engineering controls. They'll be looking closely at that, as well as the competency of the staff who are performing those activities, and then just looking to see that you're doing all the daily quality controls and monitoring that and cleaning and all the things that have to happen during the day, during each shift, during the week, et cetera, to stay in compliance with the USP requirements. Looking at just to kind of summarize, I'd say three big things. There's what's frequently scored, and that's getting staff to follow medication orders or to have physicians write orders that have all the right requirements in them for medications, antibiotic stewardship, and the compounding of sterile products. Now, I've got my bets are on two other things that get added. As you look at the survey process guide, there's a lot under the nuclear medicine module that speaks to medication management. If you do a search in the survey process guide on so it will bring up for you a list of all the pages where medication management standards are referenced. It's in the nursing module, it's in the pharmacy module, it's in the nuclear medicine module, and it's very, very clear in black and white. The pharmacist whose license covers that facility is responsible for the medication processes associated with radiopharmaceuticals. Now, they are not experts in radiopharmaceuticals, but they are experts in how you assure security of medications, how you manage medications, how you administer medications, there's compounding that happens in the hot lab, and you have staff who need to be deemed and validated as competent in performing that compounding behind the lead shield by someone who's qualified to do that. And guess that's going to be out of the pharmacy, right?
Right.
So I think that there will be more attention to nuclear medicine and radiopharmaceuticals. And then the requirements as far as conducting surveys for going to ambulatory sites are going up. They're going to be spending more time in ambulatory sites. And when I go out on mock surveys, I mean, some of the most egregious of the medication failures, it's not like life and death failures, but just not following good process, is out in the ambulatory sites where they just have a history of doing things their way.
Right.
Sample drugs are a huge problem in a lot of those sites.
Ooh, I hadn't heard.
So I think we may be seeing more nuclear medicine. What do you say, Steve?
I hadn't heard sample drugs mentioned in a long time. That's kind of a throwback.
Yeah, I was in a place recently. They had two clinics. One did an excellent job. I couldn't say don't give out sample drugs because they followed the process. And it was perfect, and it was documented in the medical record. Went to another clinic down the road at the same organization, and it was just a hot mess. It was like, okay, you have to either do what they're doing down the street, or you got to stop doing this. It's not right.
Yeah. Well, it's funny. The more things change, the more they stay the same, right? And that's kind of this whole story. And that, we went through this whole transformation years ago where they kind of pulled all the responsibilities out of the various chapters that were related to one kind of professional track, for lack of a better term, put that into a
Hmm.
chapter, right? And we lived with that for a very long time. And now they've basically blown all that up and gotten rid of the chapter approach with the modules. And it's going to be really important for people, regardless of what their discipline is, to go through this, even though the Joint Commission told us they never intended it for anybody to go through the whole thing, and see where your responsibilities begin and end, and work together as a team. So when you run across
Hmm.
something in a space that's maybe typically yours that belongs to someone else, you're like, hey, by the way, I found this standard EP that probably is more your responsibility than ours, and I just want to make sure you're aware of it.
Yeah. Yeah. So uh, when we met with the Joint Commission recently, they really emphasized, I think they recognized that they've taken things that were kind of grouped into logical, chapters, and now it's kind of dispersed because they were having to separate the things that are CMS requirements from the things that are not. And so they created this a great tool, and the link that we've provided earlier in this session will take you to the most updated version. And they said keep going to this site because we the Joint Commission are continuing to update these documents. But there's something called the disposition report. So if you got a standard, if you know what the old standard was and you have no clue where to find it now, you just go to the disposition report and search on the old standard number, and it'll take you to a place. Bring you to the page where it says, okay, that standard, it might have been deleted, but now that content is covered here, or you just not required at all. But it'll give you, if it's a new standard number, where to find that standard in and EP. Um, and then you've got all these specific surveyor guidance, interpretive guidelines from the CMS in that process guide in all these different modules. And if go to the process guide, and if you're looking for titration, if you type titration, you'll find it in several modules, or medication management, just as a general, category for standard references. And it'll show you every page in every module where you can find medication management standards or something about titration or whatever. And you're going to have to do that in order to get all the pieces of the puzzle.
Yeah. It's going to be really interesting this time next year when the number one or top 15 or top 10 or whatever, when that comes out, because they've combined so many EPs into single EPs, and they've got these much more broader
Hmm.
requirements. Like we're just kind of referencing all the USP stuff or all the life safety stuff, how that impacts the actual usefulness, for lack of a better term, of those data points. Because when it's so nondescript, how do you know, well, what do we actually need to focus on?
Right.
Hopefully they've got that figured out. They're going to say what we're seeing under these very broad categories are
Hmm.
these trends, but we'll see. I know we'll be
Yeah.
able to do that.
Yeah.
So we will definitely still have the
Edwin,
granularity.
you want to talk about the national performance goals?
Yeah. So in addition to antibiotic stewardship, there are several changes. And as Howard has alluded to, you've got to really look at the A360 standard set in whole. You can't drill down to one module and think you have everything together, because it is all over the board. There's as I've said before today, leadership is a trend within NPG. So within the changes to medication management, the first one that was changed was that the pharmacy director will be a registered pharmacist, and that is to be chosen by leadership. And now that is a NPG standard. And then, in addition to antibiotic stewardship, the anticoagulant therapy standards have been changed to NPG. So you apply leadership, you apply PI to these clinical patient safety issues or directly, and a few other ones that are specific. And again, when you read between the lines, it is a very common theme within the National Patient Safety Goals. Medication management 020101 EP6 is now NPG 140201, and this is you are to standardize and limit the number of drug concentrations available in a hospital. They're wanting to drive safety, and so that you have fewer variations of concentrations, and also that it is received from the manufacturer in that concentration. They are looking to decrease the potential errors of on-site dilution or concentration. Very focused there. The process to communicate drug shortages and outages to your providers is a standard under national patient performance goals now. And that how you substitutes, I got caught there.
Sorry, I knew the first one was going to be. So today.
It was me. The national performance goals, and also that you have written substitution protocols, so that you're not having providers just sort of by the whim or back pocket making a substitution. That you've got a evidence-based process for substitution when there are drug shortages or outages. Back to Howard's comment about offsite services or office practices, where you have 24-hour operations but don't have a 24-hour pharmacist, that leadership is a common word is accountable to assigning to a qualified leader the review before the dispensing of medications, and that once the pharmacist is on site, that review is retroactive and 100%. They've also brought over here the automatic dispensing overrides into a leadership standard within national performance goals, so that as an organization, you've got a single systematic way to define what an override is, who can do an override, and how that override is reviewed within the performance improvement process. And then finally, within this broad scope of things, is they brought over the standards about patient medication information, how it's provided to the patients and the families, what language is, what method is used, is all now part of the national performance goals. And that's in looking at patient rights. Are we giving information to a patient, their family, their caregivers in a way that, one, they understand, two, is meaningful, and reduces the chance for medication errors? So, again, a broad variety of components from MM brought over to NPG. But when we step back and look at the big picture of A360, they're looking at leadership, ownership, performance improvement, reducing preventable harm.
So from a leadership perspective, what are the kinds of things you would, if you were back in your C position, what would you want to see from the key folks leading medication management now in terms of data? How would you?
No, that's a great question, and it goes back to what you were saying earlier, Steve. And we'll be doing some minis for the C-suite. One of the practices that I found very useful, and I spoke about this in a previous webinar, is at the board meetings, having your defined quality subcommittee meeting of the board. And then running through a variety of topics over the annualized time. You don't have to cover the exact same topic 12 times a year, but to cover different things. And I would bring antibiotic stewardship twice a year to the board quality committee with the highlight of, here is our key data point about antibiotic stewardship. We did a performance improvement project that found X. We've made these changes. Board, do you agree with that? Or board, we need some resources to comply. Same thing with anticoagulant therapy. Twice a year on different times, bring that key information. Disperse your PI information over not a fire hose, but over a trickle of time, so that the board and the executive leadership have time to absorb, have time to discuss, have time to review, so that it is fresh on their mind. And if a board member is asked by a surveyor, by CMS in this methodology, they can literally say, without having to think about it, yes, we discuss performance improvement, we discuss pharmacy, imaging, nuclear medicine on a regular basis, and we understand where the executive leadership is taking us.
Yeah, and I mean, you can overwhelm people with detail, right? I mean,
High
again, I'm going
level.
back to thinking about all of this discussion that we're having about the information that's got to go to the leadership level and the board level. And you could very easily lose the message and the details if you're not careful. And I think that's going to be the challenge for a lot of folks going forward is figuring out exactly how do we what does leadership need in terms of message? How do they
Well,
look at that message?
and Lee and Steve, as you know, one of the methods that I used, it was right for my organization, and I've done it. I did it for about 9 years. Was that one message was zero harm. And if the board understands the organization's commitment to zero harm, eliminating preventable errors, you can keep it at a high level and measure it by the decrease in harm to the community that we serve.
Yeah. So how are you going? Like you're about to say something I didn't.
You know, I totally agree with what Edwin was saying. I think the challenge is how do you make a safe place for the chief quality officer to come in front of board members and say we are harming people.
Mm-hmm.
Yeah.
That's different than saying let's all agree on zero harm, and everybody will say yes, we agree, and they'll all you know leave and be happy. Um, and and I think the thing that is so hard in any organization, even when the one that I worked in for 40 years, um, what is so hard is to go to leadership with something other than happy talk about what's going on. It's so tempting. I mean, I have fallen into that temptation multiple times, which I can say now because I'm retired, but you go and you present the bright side of whatever your numbers are for the month or the quarter and try to minimize and get done before anybody wants to really dig into and ask you a question about the things that aren't as bright.
Yeah.
And
Well,
that's the only way though that improvement can happen is when people have
Correct.
those honest
well,
conversations.
they got to have
And,
it's incumbent upon leadership at all levels. And I mean, that starts with the directors or trustees and the C-suite, making sure that it's people feel comfortable bringing the hard message and asking the
yeah,
tough questions and giving the hard news. Um, and we owe it, as Edwin pointed out, to the patients that we serve. Um, and I know that it's easier said than done. A lot of organizations, they just don't want to hear it. But so
and
I'm sorry, go ahead, Edwin.
I was going to say, one of my early executive leadership lessons in exactly this topic. I was at an organization on the coast of North Carolina, and we had a CMS complaint about a patient who had fallen out of bed, broken a hip, and died. So the state surveyors came in to do a survey, and about 10 o'clock in the morning, the state surveyor said, "I'm stopping the survey. I need to meet with you and your CEO." We went into his office, and she said, "We have found that your staff does not have the knowledge how to operate the bed safely. And if you cannot prove to me by 5 o'clock today that 100% of your staff know how to safely operate your beds, we will be closing your doors to new patients."
Holy smoke.
Yeah. So I had to take a deep breath, tell my CEO, I got a plan that I put in the back of my head in 30 seconds. We had to go public to our staff and say, whether you agree, disagree, whatever, this is the finding. We have an opportunity to change and improve. And myself and 5 other staff members in 30 minutes put together a plan, and by 4:35 that day we had educated 742 people on how to operate a bed, and they demonstrated that back. We did not shut down. We did it because we were open, honest, and clear message. So Howard, back to your point, you've got to have the relationship between the leadership, the executive team, and the and the entire team to have a safe place to have an honest, uncomfortable conversation that results in patient safety.
Mhm. Yeah, and the required culture of safety survey is a good place to look. If you stratify your data and look at, so what do the people at the manager, department manager level, what do they say about their comfort in raising, here's a problem, without feeling like they are going to be punished for the problem, but that it's going to be seen as an opportunity to improve a process, not to get a new pharmacy leader, or
Yeah,
whatever. And, that's, and you can get that data if you're using a really valid tool for culture of safety and stratifying, to see, so what do our managers and people at the various leadership levels say about their comfort level.
yeah.
So
So speaking of those sorts of things, I was going to ask earlier, and I got sidetracked. But how important would you place benchmarking, either one of you, in this discussion? In terms of, when I talk about benchmarking internally, but also externally, more importantly, with peer group organizations, you think that's going to be an important part of this going forward?
I think any
start.
well-run performance improvement program uses data clearly, concisely, and is unafraid to measure against others. You have to measure against others, benchmarking, and measure against yourself. What is your goal? And the best way that Lean Six Sigma teaches you is through standard deviations. Are you one or two standard deviations off? What is your trend line? And even if your goal is zero, if you're benchmarking two standard deviations better than your peer group, the nation, you're proving through data management that you've got programs that are effective.
Hmm. Yeah. I started off as an industrial engineer in healthcare, and from as soon as computers were invented and we had data, we started to use, get people to use comparative data. And everybody will say, well, we're different, that's, it's not apples and apples, and it's never exactly apples and apples, or maybe they're apples, but some are Macintosh and some are Granny Smith,
Yeah,
but there's enough similarity that you can draw some good conclusions. And I think the huge strides that we've made in patient safety and improved outcomes in the healthcare industry in the past 20 years or so are because of the comparative data. So I'm
Agreed.
all for it.
I just heard a bunch of people gasp listening to this, saying he was around before computers.
We all were.
But we all were. But I had
Yeah.
my first one in high school, at least. But granted, it was a Commodore 64. But anyway, yeah, no, that's. I mean, I think it's really important to measure yourself internally and externally, and understand what your capabilities are. And it's good. This whole thing, with the meeting with with not the with Joint Commission a
Hmm.
couple of weeks ago. One of the things they talked about was using the checklist and the survey process guide. That they feel like they've done a really good job of empowering organizations to be successful with this. And like you said, Howard, that if you're okay in 2025, you're going to be okay in 2026.
Hmm.
Uh, and I think for the most part, that's going to be true. I think there's going to be this transitional period, much like there was way, way, way back in the mid to early 90s, when the surveyors were still learning, the hospitals were still learning, and there was kind of this kind of mutual, let's get through it and learn it together phase. Be interesting to see how long CMS allows that to happen. But with the way they've segregated the standards and really focused, what's COP directly related and kind of one bucket, if you will, and
Hmm.
everything else in
Hmm.
another bucket, in a way it simplifies that. But any other thoughts about medication management, national performance goals?
I think we've covered most everything.
I I think so.
Well,
I would just encourage, if people have questions, to reach out to us directly.
Absolutely.
And if there's anything specific about medication management, and we're glad to answer your questions.
Yeah, and I should have mentioned to put stuff in the chat when I started this, but I didn't. I guess it's a little late now since we're closing it down. For the record, I never said national patient goals today, so except intentionally, just did. It's the first one. Yay! Uh, we're getting there. We ask you, or would love to hear from you and get your feedback, and certainly. You'll be able to go and watch this later if you want. If you're an ARN member, again, remember you can get your CECs for this half-hour session. And I want to thank Howard and Edwin again for your time, your expertise, and continuing to dig in and learn more and more what seems like every single day about this stuff. We're getting close to the finish line. Well, actually, no, we're getting close to the start line is probably a better way to put it. So it's going to be
That's right.
really interesting Q1 of 26 to see how things unfold, but I think we're narrowing it down. So thank you very much. We appreciate your time, and we'll see you in 2 weeks.